So Hans, happy to have you again. And
Thank you.
today I propose we discuss about your research topic on pharmacogenomics, pharmacokinetics, and even personalized pharmacokinetics.
Thank you.
So as a starting question, could you define to us pharmacokinetics and pharmacogenomics, please?
Yes, certainly. So the drug that you take is sometimes, as a patient, is sometimes dosed per square meter. And that comes from the concept of animals to patients. So you have to start at a certain dose in a patient. So they calculate from the body surface area. That's a formula generated from length and weight of the patient, and then they go to patients. But for almost none of the oncology drugs, there's a good correlation between this BSA and the exposure in the blood. So the exposure in the blood is the measurement you take for the active compound of the drug in the blood. So the dosing of oncology drugs is a bit unsure. We work with it. We have been working with it, and it goes unexpectedly well. But we also have unexpected side effects. And on the other hand, some people might be underdosed. So when you underdose patients, you lose potential benefit for the patient. And when you overdose, you may run into serious toxicity. So there are two ways to look at that. You could do blood measurements and adjust your dose according to the blood measurement. For instance, after 2 weeks of first administration of the drug, because you have to build up your drug in the blood, and then you can adjust the dose. That's pharmacogenetics, therapeutic drug monitoring. It's being used for the oral molecular targeted drugs nowadays sometimes. And you can also do an upfront test, and that is a genetic test. And the genetic test is directed at the liver enzymes that break down the drug in the liver. And so they are important for the drug exposure in the body. And the advantage of that is that you can do it before you start. Because if you do it later, you might have toxicity already in the first weeks after treatment. So that is what we call pharmacogenetics. So that's the two sides of the coin.
Very good and clear definition. Thank you, Hans. So my second question maybe will go a little deeper in those two concepts. So first, for pharmacogenetics, could you give us some example of pharmacogenetic tests and for which drug it is used in cancer care, and what is the impact of those tests?
Yeah. So there's always the low-hanging fruit in anything. And the low-hanging fruit in the case of pharmacogenetic tests in oncology are several. I give two examples. One is the enzyme DPD, the gene that encodes for the enzyme DPD. And that is the enzyme that metabolizes, so it makes breaks down the 5-FU. 5-FU is a drug that is being used a lot in oncology. It's not a targeted drug, but it's being used a lot in combinations, colorectal, head and neck cancer, many different cancers. And we know that about 5% of patients have I would say, a alteration in this DPD gene. It's so common that I would not call it a defect, because then 5% of patients have a defect, but they have a lower expression of the enzyme, which means that the drug cannot be cleared as quickly out of the body. That means that you can have serious toxicity, and that could result, for instance, in severe diarrhea, neutropenic fever, ICU admissions, and even death. And this drug 5-FU and its oral variant capecitabine are being used also in the adjuvant setting to decrease the risk of cancer. So you have otherwise healthy patients after oncological operation, you give the drug, and if you don't do the DPD beforehand, the patient might die. So that was my personal experience with one patient, and I thought, well, we have to work on this because it's known, this gene is known, and how can we implement that? So we had an ethical problem because you cannot do a randomized study. You cannot say, if you believe in it, you cannot randomize. You cannot say, okay, I do the test, but I keep it blind for the physician and the patient, and I just start treating. And after the end of the test, I look if there's a benefit for one or the other. So you could not do a randomized study. So how to prove it then? So we did a large study in 1,200 patients, and we compared it to historical controls. And we found out that we could decrease the serious side effects, serious toxicity by 50%, by half, which is really important. And also we did a cost calculation, and you can imagine it was not more expensive to do the test because, on the other hand, if you don't do it, you have more ICU admissions, more hospital admissions, more treatment of side effects. So we were happy with that, and now it's implemented in the Netherlands to do that for everyone. And we did a sort of similar test with UGT in patients treated with irinotecan. It's less often being used, but it's a drug being used in colorectal cancer, for instance, and pancreatic cancer. And UGT encodes for an enzyme that breaks down the active metabolite of irinotecan. And again, about 5% of people have a variation. It's called Gilbert's syndrome, not Gilbert's disease, but Gilbert's syndrome. And that's the patient that have also often elevated bilirubin, a blood marker of the liver in the blood, but not always. So this genetic test can help, and we did a similar study, and now it's implemented in the Netherlands.
Okay.
So we're saving lives.
Yeah, indeed, and it has been implemented also in different countries. For example, in France, indeed, it's mandatory to do the DPD testing since 2 years.
Yeah.
So it has impacted many countries and many patients. So thanks to those explorations.
And the thing is that if you do whole genome screening on the tumor, you have to do the germline test as well. So you get a free DPD and UGT test, and it might also help for other diseases and other treatments like antihypertensive medication. And,
so I guess there are new genes that are coming and maybe related to some toxicities or effects of compounds. So could you disclose on what are the genes that are most interested right now?
Yeah, well, the cytochrome P450 star 21, if I say right, that's an enzyme involved in the breakdown of tyrosine kinase inhibitors, the modern oncological drugs. We did a study on that, but I think the group was too small, and there were also medication involved that we dose at 50% of the maximum tolerated dose, like imatinib. So it was a bit difficult. I still think that there is an interesting forward for this enzyme, but it's hard work to get prospective cohorts, and these drugs are already registered, so you're dependent on public money to do these kind of studies. Okay, maybe we could switch to the pharmacokinetics, and I've seen some works of yours on your team about a way to monitor the dosing of the drugs in patient blood, and maybe monitor the dose that the patient takes in order to be in the right concentration. So could you present a little bit this approach? Well, the oral tyrosine kinase inhibitors, I call them. It's the oral targeted drugs that you take by tablet, These are small molecules that have to enter the cancer cell to do their action. And these drugs are usually just have a flat dose, not per body surface area, not related to length and weight. So a patient from 150 kilo and a patient from 50 kilo, they take the same dose. So already from a distance you can expect that there's that's a bit strange. And so you have the feeling that there might be some threshold, minimum blood level that is needed to be effective. That's hard to show, of course, because you have to go back to the registration studies or studies where you say, okay, I see that the patients for instance, in the highest quartile or tertile, so the highest 33 to 25%, they have the best response. And then you say, okay, this level I want to reach. So we did a study for multiple drugs. That was, again, an academic initiative. And we titrated the dose a bit up or sometimes a bit lower based on the drug levels. And there were about 20 different drugs involved, and so many cohorts. It was a big study, well, we published this in Annals of Oncology. You can look it up, and it's not as easy. Probably you need bigger cohorts. You have to be more sure about your threshold, but it's still logical to do it. And for instance, in the treatment of a certain type of sarcoma, GIST, we sometimes use it still in practice when we have unexpected non-responders or unexpected toxicity, or when there is no response and we think something is wrong. Sometimes we see strange things that the patients are, for instance, not taking their tablets. It's the only way to find out if they don't tell you. So I think there is a way for therapeutic drug monitoring in tyrosine kinase inhibitors, but it has to be worked out a bit more before it can be entered in the guidelines.
Very nice. So you showed academic initiatives.
Yeah.
So are there ways to work with the industries, the pharmaceutical industries, to improve this personalized pharmacogenetics after a drug is approved? What are your experience? What is your experience on this?
Well, that's what we call phase 4 trials. The drug is already registered. You take an initiative, and the companies are generally interested. They might be more interested when you do a study where you can increase the drug, so they sell more. But that's not nice saying that, because they are also backing up kind of studies where we fine-tune the drugs that we need, because it's in their best interest to have a drug out in the market that is safe and effective. So again, pharmaceutical companies can help us there as well.
Okay. So thanks a lot, Hans, for your clear overview of this topic, and we'll see you for other topics, I hope. Bye-bye.
Thank you.